the next topic is neuroendocrine tumor of pancreas. Okay, so what is the most common neuroendocrine tumor of pancreas? Most common is non-functional tumors. Non-functional tumors, also known as VIPomas or pancreatic polypeptide. Okay, now I'll give you a basic idea regarding the neuroendocrine tumors. Neuroendocrine tumors, they arise from the neuroendocrine cells of pancreas, and they are divided into two broad categories. They are functional tumors and non-functional tumors. So the functional tumors are generally characterized by the you can say what hormone or what enzyme they are releasing. Based on the active substance they are producing, they are characterized. So they can be insulinoma, gastrinoma, VIPoma or glucagonoma. Okay, and on the other hand we have non-functional tumors which are VIPomas, that is of pancreatic polypeptide. Okay, overall if we'll see, most common tumor is VIPomas. In functional tumors, out of all these four, the most common tumor is insulinoma. But majority of the insulinomas are benign. And on the other hand, the second most common, or the tumor which is the most common and most malignant out of all four, is gastrinoma. Okay. Regarding the important points is, we have to confirm the diagnosis in this neuroendocrine tumor, at least in the functional neuroendocrine tumors, by the active substance or the byproduct of the active substance that they are producing. We'll have to first uh, measure their level, and if their level is above a certain range, then the diagnosis of the tumor is confirmed. Okay, and the second challenge is to localize the tumor. Okay, for localization of the tumor, we have a somatostatin receptor scintigraphy. So there are two challenges. First is to diagnose the tumor, which is based on the active substance that they are producing. Second is to localize the tumor, which is based on the somatostatin receptor scintigraphy. So all these tumors, they possess a somatostatin receptor, and we can use somatostatin receptor scintigraphy to localize them. But the only tumor which does not possess the somatostatin receptor and cannot be localized with the SRS is insulinoma. Okay, so for insulinoma we will have to use some other test for localization. This I'll discuss in details. Okay, so now overall if we'll see, the most common neuroendocrine tumor of pancreas is non-functional tumor or a VIPoma. Okay, most common functional neuroendocrine tumor is insulinoma. Most common functional and malignant neuroendocrine tumor is the gastrinoma. Okay, now these functional tumors, they are detected early. Why? Because they are the clinical feature, their clinical features are due to the active substance that they are producing. That is why the patient generally have some clinical features. They present to us early and are diagnosed at early stages. Okay, so the patients are symptomatic early, they are diagnosed and treated early in functional tumors. Okay. Now, what is the prognosis? If you will see the prognosis, neuroendocrine tumor versus adenocarcinoma, then obviously neuroendocrine tumor have better prognosis than adenocarcinoma. And regarding the diagnosis, I told you the diagnosis is made by the measurement of the active substance or the byproduct of the active substance. So diagnosis by measuring active substance or its byproduct. And for localization of the neuroendocrine tumor, we will have to use somatostatin receptor scintigraphy, SRS. SRS stands for somatostatin receptor scintigraphy. Other names are octreotide scan or octreoscan. Okay, so they can also ask you, octreotide scan is used for neuroendocrine tumor of pancreas. Okay, now localization or SRS is not useful, or somatostatin receptors are not present for insulinomas. Okay, now some important point regarding location of the tumor. Okay, we have 4 important tumors here. One is insulinoma, another is gastrinoma, then we have glucagonoma, and we have VIPoma. Okay, these 3 are malignant tumors. This insulinoma is benign tumor. Okay, and insulinoma is most common out of these all. Insulinoma, you will see, is equally distributed. That is head equal to body equal to tail. Okay, is gastrinoma is obviously malignant, seen in Passaro's triangle. This Passaro's triangle is at the level of head of pancreas and duodenum. So it is mainly seen in duodenum, followed by pancreas, that too in head of pancreas. Okay, duodenum, then pancreas, head. Okay, so they'll ask, gastrinoma is a neuroendocrine tumor of pancreas which is present in, most commonly in head of pancreas. Wrong, that is most commonly present in duodenum. Okay, now glucagonoma is seen most commonly in body and tail, and VIPoma is most commonly seen in tail. So this is mainly equally distributed. Insulinoma, gastrinoma more on the head and duodenum side, then the other 2 are mainly on the body and tail side. Okay, this is how I have remembered the location of the tumors. Now, I'll first discuss insulinomas. These are the basic headings of insulinoma. Insulinoma is basically insulin secreting tumor which is present in the pancreas. It is the most common functional tumor. It is benign tumor, and the patient obviously will present with hypoglycemia as there is excessive insulin in the body, and because of this excessive insulin or hypoglycemia there will be you can say symptoms which are related to neuroglycopenic symptoms. Patient will feel dizzy, there will be, you can say, coma, and there will be sympathetic stimulation, because of which there will be tachypnea and tachycardia. And how we can diagnose? The diagnosis is made by 72-hour fast test. We'll have to check insulin is to glucose ratio, and if with 72 hours fast test we'll be able to confirm the diagnosis. And how to localize? SRS is not useful. To localize, we'll have to go ahead with best is to go for EUS, endoscopic ultrasound, and intra palpation. If we want to localize it pre-operatively, we'll have to give intra-arterial calcium injection, and along with that we'll have to do a portal venous sampling. After diagnosis and localization, the treatment medically, there is a drug diazoxide which can be given. The treatment of choice for tumors involving the head of pancreas is enucleation, and for tumors involving the body and tail of pancreas is distal pancreatectomy. So this is all about insulinoma. So I'll tell you one by one. Insulinoma is the most common functional neuroendocrine tumor of pancreas. Regarding the distribution, it is equally distributed and equal in head, equal in body, and equal in tail. Nature of the disease, it is benign. It is not a malignant disorder. And what is a Whipple's triad? Okay, Whipple's triad is presence of hypoglycemic symptoms, presence of blood glucose up to 40 to 50 milligram per deciliter, and improvement in symptoms after given oral glucose. Okay, now there are presence of neuroglycopenic symptoms and sympathetic stimulation. So these neuroglycopenic symptoms are actually presence of dizziness, headache, confusion. There can be development of hypoglycemic coma also, coma. And in sympathetic stimulation, there will be tachypnea, tachycardia, sweating or palpitation. Along with that, there will be weight gain because there is excessive insulin in the body. Now, the gold standard investigation for diagnosis is a 72 hours fast test. This is a very common question, almost asked every year in one or the other MCQ entrance exam. Gold standard investigation for diagnosis of insulinoma is 72-hour fast test. They sometimes ask us, they will sometimes write it as 72-hour fast only. Okay, so this is very important. 72-hour fast test, 72 hours fasting test, or a fast test, anything can be written in the exam. And what is the insulin oblique glucose ratio that is diagnostic of insulinoma? It is more than 0.4, 0.4. So this ratio, insulin glucose ratio of more than 0.4. Obviously, you can see here that insulin should be on a higher side, glucose should be on a lower side. So if insulin is to glucose ratio is more than 0.4, then it is diagnostic of insulinoma. This is very important point. And now, whether SRS is useful or not, use of SRS is no. Okay, not useful. Why? Because there is no somatostatin receptor on insulinomas. So what is the best test for localization? Overall, if we'll see, the best test is intra-op EUS plus intra-op palpation. This is best, but this is intra-op. So if we want best is to go for intra-op EUS and palpation. Otherwise, if we want to localize it pre-operatively, just to have a basic idea where is the tumor and to plan our surgery straight away, we can go for intra-arterial calcium injection with portal venous sampling. Now the treatment is either medical or surgical. Treatment of choice is obviously surgery. A drug which is helpful in insulinoma is diazoxide, which decreases the hypoglycemic episodes. Surgical depends on the location of the tumor. If location is head, then the treatment of choice is enucleation. What is the most common complication after enucleation of insulinoma from the head of the pancreas? Okay, most common complication after enucleation is development of a pancreatic fistula. Okay, and in case if the tumor is in body and tail of pancreas, or body or tail of pancreas, then the treatment of choice is a distal pancreatectomy. Splenectomy is not required as it is a benign tumor. Distal pancreatectomy is good enough. Okay. Now the next topic is gastrinoma. Okay. The gastrinoma is also known as Zollinger-Ellison syndrome. Okay, what characterizes gastrinoma is excessive secretion of gastrin. So the more gastrin will be secreted, there will be more acid production, and there will be more gastritis, more esophagitis, more peptic ulcer. In fact, there will be jejunal ulcers, large ulcers, non-healing ulcers. Okay, or you can say refractory ulcers, so which will lead to large, multiple, recurrent, refractory types of ulcers or peptic ulcers. Okay, now insulinoma was benign and was equally distributed, but gastrinoma is malignant. In fact, it is the most common and most malignant. Neuroendocrine tumor. If a question is asked together, which one is the most common and most malignant, then it is gastrinoma. Otherwise, most common is non-functional. Most common functional is insulinoma. Insulinoma otherwise is benign. That is why most common and most malignant is gastrinoma. Okay. Now, it is most commonly seen in duodenum. Even if it is a pancreatic neuroendocrine tumor, but if you will see gastrinoma overall, it is most commonly seen in duodenum, followed by pancreas. Okay, and in duodenum also, it is most commonly seen in D1, followed by D2, followed by D3, and is not seen in D4. Okay, why there is a diagram here? Because majority of the gastrinomas, more than 90% of gastrinomas are seen in this triangle. Are seen in this triangle. The name of this triangle is Passaro's triangle, and the 3 points A, B and C are this point, and actually this point. So this is A, B and C. So it is junction of cystic duct with CBD, D2 with D3, and head with neck of pancreas, body with neck of pancreas. You can say at the level of neck of pancreas. So first is at the level of cystic duct CBD junction. Then there is D2, D3, and then there is body and neck of pancreas junction. Then this triangle, in majority of you can say majority of the gastrinomas are seen here. Okay, more than 90% are seen here. Otherwise, majority of 75% of the gastrinomas are sporadic. 25% are seen in MEN1 syndrome. Okay, so they are associated with MEN1 syndrome. Now, patient generally presents with abdominal pain, recurrent dyspepsia, acidity, gastric ulcer, peptic ulcer. Okay. Now, on endoscopy, we can see that there is presence of gastric ulcer, peptic ulcer, severe gastritis, severe esophagitis. But to confirm our diagnosis, whether that it is gastrinoma, we will have to go ahead with a measurement of gastrin levels. So, if the gastrin level is more than 1000, I'll write it with another color. If the gastrin level is more than 1000 picogram per ml, then it is diagnostic for a gastrinoma. If the basal acid output is more than 15 milliequivalent per hour, then this is basal acid output, then it is diagnostic. Suppose if the gastrin level are not elevated, but the clinical features are in favor of gastrinoma, then the best provocative test which will stimulate the gastrin production is secretin stimulation test. This is very important. Secretin stimulation test is done for diagnosis of gastrinoma. How much increase in the level of gastrin is, or the level of gastrin, if it is more than 200 picogram per ml after a secretin stimulation test, then it is diagnostic of gastrinoma. Okay, this is very important. Now we have diagnosed that it is gastrinoma. Now we want to localize. Investigation of choice for localization is SRS, or somatostatin receptor scintigraphy, also known as octreotide scan. Now we have diagnosed as well as localized. We know that the location is, in majority of the cases, is in Pasaro's triangle. Now the treatment of choice is surgical, obviously, but medication, if we want to give, which is the drug of choice? The drug of choice is PPIs. Treatment of choice is surgery, and surgery we are going to do is pylorus preserving pancreaticoduodenectomy, also known as a Longmire traverso procedure. Why we are going for surgery? Because it is malignant. That is why we will have to go for surgery. This we will be able to understand. If I want to remember only 3 to 4 points, I will first remember Pasaro's triangle. Most common location is duodenum. It is mainly malignant. Then gastrin more than 1000, BAO, or the basal acid output more than 15, and secretin stimulation test with the gastrin more than 200. That's it. These are the major points. Rest everything you will be able to understand based on your understanding. You will be able to solve. So always try to remember the important highlights of each topic. Okay. So now the next topic is glucagonoma. Okay. What is this picture? There is a patient who is having diabetes, and along with diabetes, the patient is having this type of a skin lesion. Okay. What is the most probable diagnosis in this case? The answer is glucagonoma, and the skin lesion is the most common presentation of glucagonoma. Okay, glucagonoma is also known as hyperglycemic cutaneous syndrome, because diabetes is very common and the skin disorder is the most common, in fact. What is the name of the skin disorder? It is NEM, or a necrolytic necrolytic erythema migrans. Necrolytic erythema migrans. Okay, this type of a skin lesion is seen in most commonly in the patients necrolytic erythema migrans, which is diagnostic or characteristic of glucagonoma. Now it is also characterized by a 4D. Okay, this 4D stands for diabetes mellitus, dermatitis, DVT, and depression. Okay, and this dermatitis is actually necrolytic erythema migrans. Okay, now most common location I have already discussed. The location is body and tail. Whether it is benign or malignant, only insulinoma is benign, other all are malignant, so it is malignant. How we will be able to diagnose or to confirm our diagnosis? To confirm our diagnosis, we will measure the glucagon levels. Which is the investigation of choice for diagnosis. Now we have diagnosed. How we will localize? Investigation of choice for localization is SRS, somatostatin receptor scintigraphy. Now what is the treatment? Treatment is distal pancreatectomy. Why? Because it is involving the body and tail of pancreas in majority of the patients. So distal pancreatectomy. Important. Okay. Now another important topic is VIPoma. Okay. VIPoma is, there are certain other names for VIPoma which is very important. It is Werner Morrison syndrome, pancreatic cholera, also known as a WDHA syndrome. Okay, what is the full form of this WDHA syndrome? It is watery diarrhea, hypokalemia, and achlorhydria. Okay, this is very important to remember. There is presence of watery diarrhea, hypokalemia, and achlorhydria. They will generally give potassium high or potassium low. And we will have to remember that potassium is low here. Okay, this H stands for hypokalemia. Okay, not for hyperkalemia. So there is watery diarrhea, hypokalemia, and achlorhydria. This watery diarrhea is in the range of 4 to 6 liters per day. Okay, the important thing regarding this diarrhea versus the diarrhea which occurs in gastrinoma. In gastrinoma, because there is diarrhea occurring because of excessive diarrhea occurs because of excessive gastrin. So on ng aspiration, there will be less amount of gastrin, so diarrhea will be improving. So diarrhea improves or stops. But in VIPoma, diarrhea does not improve on ng aspiration. In VIPoma, the diarrhea does not improve on ng aspiration. Okay, this is important, and this is the way how we can differentiate it from gastrinoma. Now, there is hypokalemia. What all are the other important, you can say, electrolytes which imbalance which are there? There is low sodium, low potassium, obviously. Then there is low chloride and low bicarbonate. Okay, but the thing that is increasing here is calcium and RBS. RBS or hyperglycemia is there in Glucagonoma also, in VIPoma also. Okay, so there is hypercalcemia and hyperglycemia. What is the most common location? Is tail of pancreas. Again, in the same way that we have done for the Glucagonoma. The investigation of choice for diagnosis is obviously VIP levels. Okay. And investigation of choice for localization is SRS scan or a somatostatin receptor scintigraphy scan. Whether this is malignant or benign? Yes, this is malignant. So the treatment of choice is surgery. And which surgery? It is distal pancreatectomy. But here, patient is having electrolyte imbalance, patient is having diarrhea, dehydration. Okay, so this patient is not a good candidate for surgery right now. So it is a medical emergency first. First, we will stabilize the patient. Correct electrolyte imbalance. And dehydration. Then we will go for surgery. And at that time, the surgery of choice will be distal pancreatectomy. So this is very important to understand. Initial treatment, if they are asking, in patient with VIPoma with watery diarrhea and electrolyte imbalance, initial treatment of choice is electrolyte imbalances correction or dehydration correction. Okay. And after correction, or if they are asking for overall treatment of choice, it is distal pancreatectomy. This is regarding VIPoma.